And now we switch and start doing the posterior urethra. In the posterior urethra, you have two things: posterior stenosis, that is, or contracture, which we use the terminology, that is, or if it is a trauma, we call it pelvic fracture urethral distraction defect or pelvic fracture urethral injury. And now we switch and start doing the posterior urethra. In the posterior urethra, you have two things: posterior stenosis, that is, or contracture, which we use the terminology, that is, or if it is a trauma, we call it pelvic fracture urethral distraction defect or pelvic fracture urethral injury. So, what is any fracture following or any trauma? The posterior urethral continuity is destroyed, and there is an hematoma. It is not a classical cut. There is a hematoma fibrosis complex forms between the two urethral ends. Cause is motor vehicle accident. It occurs in males, just in epidemiology. Why more commonly in males? Because they have a longer urethra, they have a fixed urethra, and the rigid attachment to the pubic bone is more. Higher risk, again, straddle fracture causes the anterior as well as the posterior. The diastasis, if there is a diastasis or the sacroiliac joint injury and a straddle, that means all the four pubic bones are injured. That is the maximum risk, and lowest risk if only one ramus of pubic bone is injured. So this is the pubic bone, the ramus. If what is straddle fracture, you get the pubic fracture as well as the sacroiliac joint behind also disrupted. So that means the entire bony complex is disrupted. And that time we have maximum chance of posterior urethra getting disrupted or injured. If only single pubic ramus is fractured, that is the lowest risk of getting the urethral injury. Now, at what level the injury occurs? So this is your bladder, this is your prostate, this is your membranous urethra, and this is your bulbar urethra. So conventionally, it was thought that it occurs at the prostato-membranous junction. So what was thought? That it happens, the injury happens at this P and M junction, but with the avulsion of the urethral diaphragm. But what is true, that it is not the prostato-membranous, but it is the bulbo-membranous junction that is the weakest point, and this is the place where the injury happens. You need to know the name of the classification system. Very rarely or sometimes you might ask to grade the injury. So we will just go through what is this classification system. So only one classification system is used commonly, that is Goldman modified, Colapinto and McCullum classification. It is mainly based on the retrograde uretrogram. It is the most common classification system you have to use. Apart from that, name of the other classification system which you learn is the Tiles and Burgess classification system. It is for the pelvic fracture. Very rarely they will be asking you which Tiles classification fracture, which urethral injury. It is very difficult to learn, not at your level. When you join your MCH or DNB program, then you're learning about this Tiles Burgess classification and in detail of how they correlate with this McCullum classification. But we'll just go through the McCullum classification just to give you some concept and grade. They can just ask you which grade injury is this, quick some common one-liners. But before that, when do you have a suspicion of the clinical suspicion? When you have pelvic fracture, blood admeatus, inability to void. Classically, you are reading it from your MBBS days itself. So that is a triad for the pelvic urethral injury. And in MS also in trauma, you have learned that amount of blood mass does not correlate with the severity of injury. Other signs which you should be, so just close your eyes and think that if there is a pelvic fracture urethral injury, so what all things can happen or what all things you can expect. Of course, you can have blood in the urine, hematuria hoga, one. Then there is you have to think, close your eyes and just think that there is a disruption at the bulbo-membranous junction. So if bulb membrane junction get disrupted, what will happen to the prostate? Prostate will go up because it has lots of connectivity from the bulbar urethra. So you will have a high riding prostate, number one. If you have got this disruption, you are not able to void. If you are not able to void, what will happen? Your bladder will get distended. Of course, if you have this injury, you are not able to pass the Foley's catheter. everything is there. And now there's a bleeding around, so you will get some hematoma. And where will this hematoma? It will in perineum. Now this perineal hematoma can go down, below, beneath, so the scrotum, or it can go up and go and die. So everything is very correlatable. You get blood in the urine. Now you start when there is an injury. So what happens is there is a disruption. You cannot pass the Foley's catheter. You cannot pass the Foley's catheter. You are not able to void. You're not able to void. You have a distant bladder. Prostate got lost its continuity with the bulbar urethra. Goes up. It's a high riding prostate. That's all. You're done with your clinical features. What happens to the pre-operative? What do? First, you do always ultrasound. Ultrasound fast in trauma. Ultrasound. You do it. You see what is happening. Bladder. Bladder is distended. That's all. Then what you go again? You do for a RGUMC. You do a push a pass a dye from the down, and you see either it's going to bladder. No, it will just stop there somewhere. You do an MCU if you have a supraview access, or if you are able to pass the dye, full the bladder. Ask him to work. There's an MCU doesn't routinely you're not able to do with your trauma settings. You do an RGU. Upcoming tools, ultrasound. When you do ultrasound, you can see where the structure. Very difficult to see the posterior urethra. Just see the bulbar, some membranous portion. That's all. You can't do an ultrasound maximum mainly for the bulbar access. Okay. So dot to here. Coming to the MRI. MRI is done in severe case of bladder neck injury. You don't know, have an idea where the urethra has gone, where the prostate has gone, where the bladder neck has gone. So at that way, you do MRI, and the gold standard is the endoscopic evaluation as always. Now we come to the quickly. We have 2-3 slides which will help you understand what is Colapinto and McCallum classification as per the Goldman modification. So first thing you have to learn. So I'll just need a blank slide. That you have 1 to 5 injuries. So you have 1, 2, 3, 4 and 5. Simple. Now how the injuries have been graded and what happened. So first we have to learn what are we going to see in the anatomy. So this is your bladder. This is your prostate. This is your urethra. What are the 3 or 4 structures, and this is your bone. So these are the 4 things which we are saying: the bone, the bladder, the prostate and the urethra. Okay. And now what are the structures which are anchoring it? So this is your diaphragm, urogenital diaphragm. These are the level 2 structures which we have to remember. And there can be the puboprostatic ligaments. Okay. Which are happening, injury happening. Now line say we'll just learn what happens when the injury is happening to what. So if the injury is happening only to the ligaments, if the injury is happening only to the ligaments, so what is happening? Your diaphragm is intact, your urethra is even intact. The only injury is happened. So urethra is intact, your diaphragm is intact. It is a type 1 injury. Only puboprostatic ligaments are damaged. Now, apart from this, if the ligament, you have the urethra also damaged. So the ligament is also damaged and urethra is also damaged. But your diaphragm is intact. Then it is a type 2 injury. Now, if the 3 structures, the ligament, the urethra and the diaphragm, all the 3 are opened up. The ligament, the urethra and the diaphragm. All the 3. So 1, 2 and 3. All the 3 things are. Then it is a type 3 injury. So membranous injury, diaphragm injury, and of course ligament has always been injured. And you have the contrast is going out into the extraperitoneal space because the diaphragm is now open. That's a type 3 injury. Type 3 is the most common type of injury. Now we come to type 4 injury. So अब क्या बचा डैमेज को? अब बचा ब्लैडर. आपने ये भी उड़ा दिया ही, या आपने लिगामेंट जो इंजर कर दिया आपने, दैट इज द लिगामेंट इज आल्सो, द यूरेथ्रा इज आल्सो, द जेनिटल. Now you have the bladder. So if you are contiguously involving the bladder, that is type 4 injury. So bladder base injury. So the problem is continuous. That's why. Now there was some scenario in which the bladder neck per se is intact, but extraperitoneal some portion surround near the bladder base got injured. So that we call it type 4 injury. or a female injury is called type 4. So this is a separate classification. Basically type 4 was normal with bladder base involvement. So simple was type 1 urethral ligament, type 2 ligament with urethra, type 3 ligament urethra diaphragm, type 4 bladder base, and type 5 something anterior stricture. So that was simple 1 2 3 4 5. Then 4a came into the picture, that it's not a bladder base exactly, but para bladder neck, that is near the bladder area extraperitoneal injury has happened, or a female urethral injury, that was classified type 4. So if a bulbar urethra is involved, it is type 5 injury. So here in this, the continuity is maintained. There is no contact excavation. So it is of course type 1. There is a lengthening of the urethra, stretched, but so ligament is torn, but everything is intact. Here you see that the contrast extravasating, but it is limited here. So it is a type 2 injury. That means urethra is torn, ligament is torn, but the diaphragm is intact. Okay. Now in type 3, here the diaphragm is torn, that the contrast is going beyond. It's going into the extraperitoneal space. Now in this type 4 injury, what is happening? You have the contractation. Of course, this is the injury area, and you also have a extravasation here. So the bladder base, contravasation, external bladder base. So, and you see the pear-shaped bladder because the hematoma is there. And if you have an injury in the bladder, bulbar region also, along with this, you have a bulbar urethra injury. It is type 5. It's not that difficult classification. Only you should know it, and you can just have an idea now. So you can say, what will be asking you? Female injury is type 4a. They can ask you that if the bladder base is not involved, but the bladder near the bladder base is involved, and the extraperitoneal vasation is there, it's a type again 4a. Or if there's a, normally they ask if there's a bulbar urethral involvement along with the posterior injury, then it is a type 5 injury. Okay, that's commonly they ask. You know, to ask you 1 2 3, but you know it. 1 is pure ligament, 2 is ligament with urethra, and 3 is ligament urethra and the diaphragm. Now coming to the management of the stricture urethra. So when you come to the management, first thing, patient has come with a trauma for you in emergency. So what is happening in emergency? You have to ask, patient is not able to pass urine, there is blood at meatus, inability to void, you have suspicion of a pelvic fracture urethral distraction defect. So when you have a, you have to divert, you have to pass a catheter. So now first question is, should I pass a catheter or should I not pass a catheter? So conventional teaching, classical teaching, if you are giving your post MBBS MS exam, so just do a retrograde or do a suprapubic diversion. But practically now you are entering an MCH entrance exam. They don't want you to answer that you are doing to go do an emergency retrograde immediately. Their options, first, standard, yes, you should, if you are not able to pass a catheter, if it is blood at meatus. If the options are like either you do a open exploration, no, you don't do an open exploration, or you directly go for an open pubic suprapubic diversion, no. The first option is you assess and you say you can do, if the option says a gentle catheterization attempt is reasonable. Now as a urologist, a gentle catheterization attempt is reasonable. What are the problems? Why don't we do it? Prevent the potential conversion of partial into complete injury and infecting the pelvic hematoma. Don't infect it. So if you have any resistance, then you go for a retrograde urethral. Okay, so gentle attempt of catheterization, often over a guide wire, or it could be done. But if you have some doubt, if you're not able to do it, then you just immediately do a suprapubic urinary diversion. So this is how the question has to be approached. That exactly what they are trying to ask. If they are trying to think in that way, it's a simple latent blank question. Subdiversion or RG retrograde, it's okay. If they give an option no, a gentle attempt can be done, keeping in view not to convert into complete injury with complete sterility, no infection, then yes, it could be attempted. Now what next? Initially you have done we have some diversion, you don't have to pass. Now should I go for an immediate surgery? Should I go for an immediate surgery in patients with pelvic fracture urethral distraction defect? The answer is completely no. Why no? Why don't you want to immediately open an anastomosis? No, because there is a high rate of impotence incontinence, there is a release of pelvic hematoma and compression, so uncontrolled bleeding, and rather which was an incomplete injury, now you have dissected out, it will become complete injury and you're not able to find the end, you're not able to anastomose or enter it. So immediate surgery, patient has come to trauma, immediate surgery, no, always no is the answer. Except when do you do immediate surgery? If it is a penetrating injury, you have some sharp bullet, something, you have to take it out. If you have a bladder neck injured, you can open it and repair that simultaneously. Or if you have some rectal injury and you are going to open it, then you can attempt immediate injury, because now you are anyway going to disturb the hematoma. So immediate surgery indication only this, otherwise you don't do any immediate surgery. Now the second is when to do a primary realignment. That means, what is a primary alignment? It is not actually we are trying to align the urethra or we are trying to anastomose. No, we are just trying to shorten or the length, or we are just trying to realign. That means trying to maintain the urethral continuity if possible. Generally, it can be done with endoscopically. You can just put a guide wire and just try to put a catheter over it under endoscopic vision when it should be done. So primary realignment, first, what are the techniques? You can simple pass a catheter, you can do it endoscopically, you can use a railroad technique. You just need to know the name, railroading. You put a lot of catheters one by one, try to railroad. Or there is one more technique that you put prostate traction on one way and you give perineal traction and try to pass the catheter. So ultimately you are trying to maintain the luminal continuity. It is not done commonly, but if you're trying to do it in a stable patient, you can do it after 1 to 2 weeks or even immediately if it is feasible. But you should not cause no more harm. So primary, not a standard of care, but you can attempt it within 7 to 14 days. If you have a short urethral stricture, you've seen as a small disruption, you have done a RGU and a stable trauma patient, you can try a primary realignment. What is the advantage of the primary alignment? Later it has been found that it makes your surgery easier, it has better continence and better potency rates. The standard answer is a delayed surgery. You immediately pass the urine, do a super diversion, and after 6 weeks minimum, you do a delayed surgery. So, what is the delayed surgery which you have to learn? You have a perineal approach, you have a transpubic approach, normally you have a perineal approach, you have a Webster approach, and it is again an end-to-end anastomosis. So, now you don't have to confuse between the end-to-end anastomosis of the bulbar urethral stricture with the posterior urethral stricture. This is the most important thing. Again, we are doing end-to-end anastomosis. Here what we are doing, the membranous urethra has got damage. We have a bulbar end, proximal bulbar junction there, and we have a prostatic end, and we are going to do a anastomosis between them. So we don't classically call it excision because there is nothing, a strictured segment per se. The hematoma complex is there, fibrotic complex is there. We don't call it excision per se. What we call it progressive perineal urethroplasty or progressive perineal approach. That means we again, patient lithotomy position, we are going to find out the ends of the urethra which is strictured just like a bulbar, but this time we are not directly seeing the bulbar region. We have to lift off the bulb and we have to dissect between the planes of the urethra and the rectum. We are going to dissect anterior to the rectum and we have to find the complex. We have to find the proximal opening, which is the prostatic end, and here, which should be the bulbar junction, we are finding the distal end, and we are now going to anastomose it. And we have to take out that callus. We are not able to dissect the callus, we just dissect around, and the purpose is we have to just maintain the continuity, but in a tension-free manner. And how do we do it? So for that, we have got certain maneuvers that we can go, which call it a progressive perineal approach. What we call it? Progressive perineal approach. That we have opened up the patient, we have got the distal end, we have to find the proximal end because there is all hematoma and fibrosis. So what we want a proximal end to come to us and distal end or to go with it, and we just want to anastomose. How do you do it? First thing, you mobilize it. So first thing is urethral mobilization. You mobilize the urethra all around, distal end, because proximal you're not able to see much. You're just trying to put the distal end inside, going into proximal and try to anastomose. If not possible, then So we have mobilized the urethra both proximally and distally. Of course, after mobilization, if I'm not able to get the space, then urethra is getting attached with the cruras. You have got a crura called cavernosa and crura spongiosum. So we try to mobilize the crura. We mobilize the urethra from the crura because that is the point where it get attached, anchored. So we just separate free. So we are going to separate the crural bodies. That give us some more length. If not, then we have to cut the bone because it is coming like this. This is the bone, urethra is coming like this. So if we cut the bone, it gives a more straighter course. It can come directly rather than going that curve. So that is called inferior pubectomy. And if not that possible, then we have the crura is coming like this from the bone. The crura is coming like this. Urethra is coming like this. We can take instead of urethra passing between both the crura, we can just take a lateral simple view and just pass the urethra directly through the crura. That is called supracrural rerouting. So for your point of time, just you have to maximum read these four things: mobilization, separate crural bodies, inferior pubectomy, crural routing. That is the concept of perineal urethroplasty for posterior of the pelvic fracture urethral distraction defect which occurs in the posterior urethra. Am I clear? Don't get confused. It is too much of information, I know, for you because you have never seen urethroplasty or unlikely to be seen urethroplasty or preparing, but still we are trying to tell you some concept of the pelvic posterior urethral injury. That is कि अगर आपका posterior urethra is getting damaged, purpose is again anastomosis. It is like end-to-end anastomosis only, but this is time it is not happening in bulbar urethra, it is happening in the posterior urethra, that is between the prostatic urethra and the proximal bulb or a membranous end. Beach mein there is all complex and we are trying to suture it. In a way to suture it, we have to mobilize it. So this is a figure which summarizes you what places what is happening. So we are talking about this right now. Mobilization, we separate the crural bodies, pubectomy and rerouting. This happens here. When the stricture is in the bulbar urethra, we are just doing the mobilization, bulbar mobilization and just dividing an anastomosis, excision anastomosis. And here we are using the graft in the penile. So similar concepts, and meatus is a meatoplast, that's not commonly used. So these are the three places we are, concept is same but three different things we are talking. In the pelvic fracture urethral, we have mobilization, we have rerouting, but ultimately we are doing the anastomosis only. In bulbar urethra also, both the hands we are doing the excision anastomosis. We are not excising exactly, we are trying to dissect off the calyx, sort of excising but not true excision, and then we are just trying to achieve the continuity here. This is the pictures which we show. So these are the maneuvers which we do. That is, first mobilization of the urethra, second we do the separation of the crura, third we do pubectomy, and the fourth is the rerouting of the urethra. First is the mobilization, second is, these are the two crura, okay, and the urethra is going between this, so we separate these two. So this is one crura, this is another crura, this is the urethra which goes in between these two, okay. No one is going to ask you in detail these things, so you don't have to really worry if you're not able to understand it, but then you just have to get an idea so that in MCQ if you get these four options and you're able to just take it out. So mobilization, separation of crural bodies, inferior pubectomy, supracrural rerouting. Okay, your mummy सबकी Instagram post से रो रही है. So you can just have a mnemonic like that. Your mummy सबकी Instagram post से रो रही है. If you like the mnemonics, so that you can just have your mummy सबकी Instagram post से रो रही है. Okay, not a very good mnemonic, but it can help you. So there are certain things which are just to mug up, like the name of the penile flap. You have to mug them up. There's no other way I can help you. Orandi, Turner, Warwick, McAnish, concept Q flap. Similarly, perineal urethroplasty in PFUI 4 concept, urethral mobilization, crural separation, inferior pubectomy, and supracrural rerouting. Your mummy सबकी Instagram post से रो रही है. That's all. So pubectomy, just a word about pubectomy. When the defects are larger than 3 centimeter and you have previous failed repair, then you need a pubectomy. Problem is bleeding. You have a dead space there. That's all.